Hello, everybody, and welcome to another lunchtime continuing education webinar. That should be better, hopefully visually for you. This topic today is osteoporosis, bone density, evidence-based nutritional lifestyle interventions for prevention and complementary management, a very important topic for practitioners who are doing, musculoskeletal work especially. So let's start from the beginning. So the World Health Organization defines osteoporosis as someone having a bone mineral density that's more than 2.5 standard deviations below that of a sort of a healthy young individual who's about 22 years old. But then in 2005, they updated the definition to say it's not just about bone mineral density or how much calcium and magnesium and minerals are in bone, but also about the bone architecture. When you do resistance training and weight-bearing exercise, it's not just that you track calcium into bone, but you build more of the protein like collagen and osteocalcin beams that hold bone together. So that's sort of the microarchitecture. So that needs to be factored into bone mineral density or bone density assessment as well, because doing resistance training, as you're going to see, and as you already know, helps not only to keep minerals in bone, but also to build more of the bone architecture. So it's not just about taking supplements and ensuring nutrition is good. Physical activity is critical. But the incidence and trends of osteoporosis are very disturbing. 1 in 4 women over 50, 1 in 8 men over 50 develop osteoporosis. The cost to the Canadian healthcare system as of 2010 was $2.3 billion a year. In the United States in 2005, $17 billion a year in osteoporosis management. And osteoporosis and low bone mass are currently estimated to be a major public health threat for almost 44 million US men and women aged 50 and older. 55% of the population that age range over the age of 50 are sort of at risk because their bone density is not great. So, 1 in 2 women, 1 in 4 men over the age of 50 develop a fracture at some point in their lifetime. The cost to manage that in the United States is about $40,000 per fracture. In Canada, we have about 30,000 hip fractures annually, and the direct cost for each fracture is almost the same. It's almost $35,000 to manage each fracture because the long-term hospital stays and all the other surgical things to go with it. So it's a very serious problem here that really doesn't get spoken about enough. And the practitioners who are managing sort of musculoskeletal conditions should really have this on their radar because it's been falling through the cracks. So you see in Canada, osteoporosis affecting this percentage of women and men. 75% hip fractures in Canada in people over 75, but 21% in people 50 to 74 years old, still really in the prime of their life. This is the most disturbing fact for me, and that is the death rate for women in Canada from osteoporotic fractures is greater than the combined death rate from breast and ovarian cancers. So it's like we have some idea how to reduce the risk of breast and ovarian cancers, but we don't have all the complete understanding of that. We have some ideas that look good, and women who have certain practices, it seems to help to reduce the risk to some degree. We don't know how to eliminate those cancers. With osteoporotic fractures, we pretty much know how to prevent this from ever happening. And yet it actually claims more women's lives each year in Canada than the death rate from breast and ovarian cancer. So it shouldn't happen to any of your patients or clients. So right now, up to 20% of women and 34% of men who fracture a hip, they die in the first year because they fracture a hip, they go in the hospital, they lie down, they can't move, fluid collects in their lungs, it becomes a pooling ground for bacteria. They're already a little bit older, so their immune system's weaker, they get pneumonia, and they die. That's typically what happens. And so it affects more men than women this way because it's usually men are more elderly when this happens to them. So you see that nearly a third of women and 6 men fracture their hip in a lifetime. These are really high numbers. And of course, you also get the fractures of the thoracic vertebral bodies leading to the Dowager's hump, which really, it doesn't look good. And also it compromises the person's quality of life. Then they need a walker. And I look at people like this and I think, God, this could have been prevented. And of course, when you lose bone density in the hip area, that becomes porous. All you need is a small fall, and that you fracture the neck of the femur. It's devastating. You know, it's to come back from that when someone's older is very hard. So the trick is really to prevent this from being having these bones be at risk in the first place. So the two really, how much calcium and bone mineral density can you accumulate over the first 2 decades of life up till about age 20 or 25? And then after age 35, what is the rate of your bone loss? Those are the two factors that are going to determine bone density. So unfortunately, we see that young people who are, up to age 20 years old, especially during the teenage years when you can really accumulate bone density at the greatest rate because the fractional absorption of calcium is so fantastic. So teenagers are not educated well enough, in my view, to help them really optimize their bone mineral density. So then after age 35, if people aren't taking the other precautions, then the rate of bone loss really speeds up. And this leads to the kind of bone loss that typically causes fracture. So, men and women start losing some bone density after the age of 35, but after menopause, as estrogen levels drop off, women can lose 3 to 5% of their bone density every year for the next 10 years. They can lose density from age 50 to age 60. So this is where you educating them and putting the strategies in place to prevent this becomes critically important. Men tend to lose bone density at a faster rate after the age of 65. That's when testosterone levels have really declined to a significant degree where you're getting less of that anabolic effect from the testosterone. So this is the diagnostic classifications of bone density from the World Health Organization. So normal bone density would be bone mineral density reading that is not more than one standard deviation below that of a healthy young adult. Osteopenia, which is that sort of gray area in between, is when you have a bone mineral density decrease that's between 1 and 2.5 standard deviations below that of a healthy young adult. And then once you get beyond 2.5 standard deviations below, now you're into pure osteoporosis. But osteopenia also carries risk. Severe osteoporosis is when you have decreased bone mineral density in your osteoporotic, but you've had a history of some fragility fractures earlier in life. Let's say you were skating and you fell down, you broke your wrist, or you broke your rib, with some kind of innocent maneuver. So those are fragility fractures, and then you combine that with osteoporosis. Now your risk is significant. So osteopenia alone carries a 2-fold increased risk for fracture. Osteoporosis a 4 to 5-fold risk, and the presence of pre-existing fractures with osteoporosis, a 20-fold increased risk that there's going to be future fractures. So the way to really determine bone density is with the DEXA machine, right? It's a fancy kind of X-ray machine that can sort of look at systemically understand what is the bone density of the individual. That's really the only valid way to do it, other than some in-office sort of ultrasound versions, which we'll talk about. An estimated 70% of hip fractures are related to osteoporosis. So in Canada, you can fracture your hip in a really bad car accident, even if your bone density is good. But 70% of hip fractures occur in people with osteoporosis. And as we said, peak bone mineral density occurs in young women. They reach their peak at around age 20. For young men, they can increase bone density up to age 25, sometimes up to age 30. So that's what the DEXA machine looks like if you've never seen one. But remember that regular X-rays that maybe a chiropractor would take, or a family doctor, looking at just, looking for any other types of lesions other than, looking at for pure bone density reasons, don't really tell you a lot about the person's bone mineral density until you've lost a very significant amount of it. So relying just on flat films as your measure of bone density is not the best thing to do. Also, blood calcium levels are not a reflection of calcium nutritional status. Your blood calcium will always be in the ideal range, because as soon as it's not in the ideal range, you go into, if your calcium level is low in your blood, you go into hypocalcemic tetany. Or if your calcium's too high, you go into hypercalcemic tetany. That's all your muscles go into spasm, including the muscles in the air passageways, and you have asphyxia. You can't breathe. So the body will do everything it can to maintain normal calcium levels. It'll borrow calcium from bone to do that. It doesn't mean that your calcium nutritional status is great. It just means that your blood calcium is in the ideal range. But you might be taking calcium out of bone to maintain your blood calcium levels so that you don't go into tetany. So that's the thing to understand here. So the question is, who's at highest risk and who should have a bone mineral density test? Well, women who have an early menopause because their estrogen levels have dropped off earlier, they had bilateral oophorectomy, before menopause, they had their ovaries removed. Younger women with any kind of ovarian dysfunction, amenorrhea, or they had eating disorders, their body weight was really low, they were gymnasts or something like that, where their body fat was so low they weren't producing that extra estrogen from their body fat stores, and they've missed periods over their lifetime, or they had very irregular periods. They're at higher risk because of less estrogen to drive calcium into bone. Women not receiving hormone replacement therapy within the first 5 years after menopause. Well, most women are not on hormone replacement therapy anymore because it increases the risk of breast cancer, possibly endometrial cancer, stroke, heart disease. So doctors don't prescribe it the way they once did for those reasons. So a lot of women don't have hormones going into support it. When I'm not saying that they should have those hormones. I'm just saying that today, a lot of women, they used to have it in the 1990s. A lot of women were being prescribed those hormones. Today, they're not being prescribed so much. And then there are oral glucocorticosteroid drugs, like prednisone. If anyone who's on that for 3 months to reduce an inflammatory condition or autoimmune disease, it also causes demineralization of bone, so they're at risk. People with primary parathyroidism. What does parathyroid hormone do? It pulls calcium out of bone to maintain normal blood calcium levels, but you're leaching calcium out of bone. People with family history of osteoporosis should be investigated. Men over the age of 65, if their testosterone is low. People who are underweight, they have very poor muscular development. They're very frail, fragile-looking people. They should have a bone mineral density test. People on anticonvulsant drugs like Dilantin and these phenytoin types of anticonvulsant drugs, they interfere with vitamin D metabolism, increasing risk of osteoporosis. So these are the people that should be on your radar to the highest degree, where you say to them, have you had a bone mineral density test? If they haven't, then you write a note and you say, take this to your physician. I really think you're a candidate, may have just slipped through the cracks, but your doctor should be ordering a bone mineral density test to see what your status is. From there, we can make some intelligent decisions about how to maintain your bone density, try to bring it back, slow the rate of loss. Now, some practitioners have these in-office fantastic sort of ultrasound-based technologies that can do a pretty good job of actually measuring bone mineral density. So if you have that technology in your office, then that's very, very admirable in my opinion. So who's a candidate for aggressive bone density intervention? Well, people with osteoporosis, of course, and people with osteopenia are often prescribed medications. So what are the medications? The drugs that help to reduce further resorption of bone, like Fosamax and Actinol, right? These are these bisphosphonate drugs, and they do a pretty good job of slowing down more calcium being lost, but they don't put more density into bone, which is something that you need to do. And then there's some other drugs they might use on occasion, but these are really difficult drugs to use, like calcitonin, which has all kinds of horrible side effects. Some of these selective estrogen receptor modulators, like raloxifene, which is sort of an estrogen modulator, sometimes parathyroid hormone. And then, of course, hormone replacement therapy with estrogen, which can increase risk of cancers and stroke and heart disease. So a lot of these things are not being used. The primary go-to medications are the bisphosphonate drugs like Fosamax. But nutritional factors in bone density are a really important feature of the discussion that sometimes doesn't get emphasized to the degree that is required. And it's not a one size fits all formulation. It comes down to understanding a lot of moving parts to that particular patient. But let's look at the nutrients and we'll see how it all fits together. So with respect to calcium, it's the major component of mineralized tissue, including bone and teeth. And an individual who's 9 or 10 years old can absorb 140 to 165 milligrams of calcium a day. But once you get to be age 11 to 24, now the body has the ability to absorb 400 to 500 milligrams of calcium a day. The fractional intestinal absorption, that's the genetic window in a person's development where you can really accrue a lot of calcium and other minerals into bone and get the maximum bone mineral density by the time you're 20 or 25 years old. Unfortunately, that's not the behavior that young people have because no one's explained it to them, or they don't think it's that important because they're so young, they're immortal. But peak bone mineral density is you tend to reach that between age 20 and 30. So the evidence suggests that adding an additional 500 to 1,000 milligrams a day of calcium to the current calcium intake for adolescents, it can increase their bone accretion rates very, very significantly. So the National Institutes of Health back in the 1990s did a very smart thing. They raised the calcium recommendation for for individuals in this age group to 12 to 1,500 milligrams a day for individuals 11 to 24 years old. So if you have young people in your office or you have parents who have teenagers, this should be part of your educational message to try to get their bone density maximized, not just thinking about older people, but there's the opportunity when people are young to maximize their bone density so they have much more of it. So even if they lose some bone later in life, they don't reach the fracture threshold nearly as easily. Presently, the average calcium intake in that age group is 900 milligrams a day, and you're trying to get it to 12 to 1,500. So these are the actual numbers that the National Institutes of Health consensus panel came up with, which I really like. So you see that, these sort of people in their teens, 12 to 1,500 milligrams a day, that's the target. And then once you're 25 to 50 years old, you can level off at probably 1,000. Women who go into menopause who are not on hormone replacement need 1,500 milligrams a day. If they're taking hormone replacement, then probably 1,000 milligrams is enough. 65 should be thinking 1,500. Men 50 to 64, at least 1,000. And once a man's over 65, they should be looking at a 1,500 milligram ingestible amount of calcium each day from food and or a combination of food and supplements. The average US diet contains about 600 milligrams a day. So most people are well short of this. The thing is, if you're going to use calcium supplementation, understand that your body can only absorb 500 milligrams at a time. If you put in a dose of 1,000 milligrams at one time, you'll absorb a lot of the first 500 milligrams, probably about 30% of it or 34% of it max. But the next 500 milligrams, you're absorbing none of it. So you need to sort of space out your calcium intake so you get maximum absorption with each dosage, whether it's from food or supplements. And the preferred time to take calcium supplements, a lot of people think, I take calcium on an empty stomach before I go to bed, it helps with sleep. I'm thinking, well, that's not the time to take calcium. The time to take calcium is with meals, because calcium is absorbed much better with many factors in food, like fat and lactose and other things that can enhance calcium absorption. And even though calcium carbonate, that form of calcium supplement, has more calcium per tablet than calcium carbonate will have more calcium per tablet than some other forms of calcium, such as calcium citrate, which will be 23%. So you'll probably have seen studies showing, and I'll show these to you, the calcium citrate, that calcium gets absorbed better. But because the citrate molecule is so big, that to make something that a person can actually swallow, the caplet size can only be so big. And so you actually have less total calcium there. Whereas with calcium carbonate, the carbonate molecule is very small. You can attach a lot more calcium to carbonate and deliver more calcium to the individual. We'll look at this in a moment. The other thing to know is, what is the upper tolerable intake level of calcium a person can take? It's about 2,000 to 2,500 milligrams a day. The body has ways to prevent more calcium getting absorbed than is necessary. But once you go beyond 4,000 milligrams a day, you're asking for calcium toxicity, which can actually calcify your internal organs. So, you need to be in the right range, not in a range that's, in outer space. So the recommendations that I showed you from the National Institutes of Health are actually based on the North American dietary pattern, where people eat a lot of animal protein. And when you eat a lot of animal protein, it tends to generate more acidity in your bloodstream, because a lot of these sulfur-containing amino acids get broken down in the liver into sort of sulfuric acid. It creates acidity in the bloodstream, and to acidify, to buffer that acidity, you very quickly use up the bicarbonate system in the bloodstream, as well as hemoglobin and other things that can step in. And then the next thing you're going to use to buffer that acidity is pulling calcium out of bone to act as a base. So the reason why we need more calcium in this part of the world for bone density is because the other dietary things that we have surrounding it tend to increase the amount of calcium that we need to overcome some of those factors. The other thing is that so a person's absolute calcium need must factor in a number of variables, like how much animal protein they're having. Also, as you're going to see, caffeine washes calcium out, alcohol washes it out. If a person's not exercising, they're losing calcium at a faster rate. Is there a family history of osteoporosis? What's their vitamin D status? What's their parathyroid hormone status? What other drugs are they on? What's their risk of colon cancer? You're going to see that more calcium may help to reduce risk of colon cancer. So you have to put the whole clinical picture together when you're making recommendations. But what's critical to know about the absorption of calcium is that it doesn't matter what form of calcium you put into your intestinal tract. About 25 to 35% of the calcium you put into your body will get absorbed. And the other 65 to 75% is not getting absorbed, no matter what. And so certain things from certain sources, calcium absorption is a little bit better than from other sources. So from milk, which is really the gold standard for calcium, studies have shown this repeatedly, that dairy products, not only do they deliver a lot of calcium, but that calcium is highly bioavailable and can be very helpful in supporting bone density. The presence of lactose and fat, and if the milk is fortified with vitamin D, all these things are enhancing calcium absorption. The plant sources of calcium are less bioavailable, but they're still good. You're still going to get 25% absorption of the available calcium. With calcium supplements, it's going to range between 31 to 40%. But the absorption of calcium, even from supplements, is more largely dependent upon other factors that are occurring in the gut simultaneously. So factors that inhibit calcium absorption and or encourage the urinary loss of calcium are a high intake of fiber. A lot of fiber has a negative charge to it, like phytic acid, oxalic acid, and it'll actually attract calcium because it has a positive charge. It'll bind it so the calcium can't get absorbed that well. Lack of acidity in the intestinal tract inhibits calcium absorption. So as people get older, sometimes doctors put them on these proton pump inhibitors, like omeprazole and other drugs and histamine blockers and antacids. And it's like that inhibits calcium absorption and is very much linked to increased risk of osteoporosis over the long term. A high sodium diet tends to wash out more calcium through the urine route. Alcohol washes out calcium. Caffeine washes out calcium. Low vitamin D status, below 50 nanomoles per liter. You're asking for decreased bone density. Cigarette smoking. Not enough fruit and vegetables. Fruit and vegetables give you a lot of potassium. Potassium can act as a buffer in the bloodstream, so you don't have to borrow calcium from bone to act as a buffer. That's one of the ways that potassium helps to spare bone density. And if you have a high phosphorus diet, without the right amount of calcium, you're asking for trouble. So someone who's just drinking 7-Up and colas and Diet Dr. Pepper and all this phosphorus without any calcium, they're sort of asking for trouble. So these are the references for that calcium absorption and urinary loss. So if you look at calcium supplements, you'll see that from different types of supplements, there's the absorption rate varies. So you see from calcium carbonate, it's 31%, and citrate, it's 40%. And you're saying, well, citrate's obviously better. It's not really better because carbonate is such a small molecule, you can attach a lot more calcium to it to make up for the difference. With citrate, the citrate molecule is very large. You can't attach very much calcium to it to make the same size caplet. And you can't be making bigger and bigger caplets because people can't swallow them. So there's a maximum size caplet that you can make. So there is this thinking out there that calcium carbonate is just like a piece of chalk. It just forms stones. It fills up people's septic tanks. It doesn't get absorbed, which is complete misinformation. Calcium carbonate is a very reliable and good source of calcium supplementation for bone density. Many studies have shown this. Most of the calcium and bone density studies that have been done have used calcium carbonate because it's the least expensive, so it's most accessible for research studies. And it's shown very, very good outcomes. It's the dose, it's the timing, and it's the other peripheral factors that determine how well it's going to be utilized. But you can see the other different types of calcium that are in play here. Calcium absorption can be enhanced by taking supplements in divided doses, no more than 400 to 500 milligrams at a time, as I said earlier, and it should be with a meal. Now, when you take calcium with a meal, the advantage is not only is the absorption of the calcium better, but the calcium that remains in the intestinal tract, if there was some fat at the meal, the gallbladder is going to secrete some bile acids into the intestinal tract. And the bile acids don't return into the body through the enterohepatic system, stay in the intestinal tract and become part of the fecal matter. And as it goes through the large intestine, the gut bacteria can metabolize bile acids into secondary sterols, which can induce colon cancer. Fortunately, the calcium that you don't absorb attaches to the bile acids, forming insoluble calcium soaps, preventing their conversion into these cancer-causing secondary bile acids known like lithocholic acid and deoxycholic acid. Studies show that for every 300 milligrams of calcium you consume, you're reducing your risk of colon cancer by 8 to 9%, whether it's from food or supplements. And for blood pressure regulation, that calcium that you have with the meal can help to wash out any extra sodium you had at the meal through the urinary route, because calcium and sodium sort of compete, sort of trying to push each other out through the urinary route through the kidney. So more calcium intake helps to flush out more sodium so it doesn't raise your blood pressure. So more calcium can help actually lower blood pressure in people that are sodium sensitive, hypertensive individuals. So here's some research on that if you want to read it. In terms of calcium levels in food, if you look at milk and yogurt, 300 milligrams in 8 ounces, which is a significant amount. And then I only put low fat sources up here because a lot of dairy products and other foods that have calcium, if they're high in saturated fat or trans fats, I'm not going to show that to you. I don't want your patients eating those foods. Like I can show you ice cream, and there's calcium in ice cream, and cheesecake. I can show you that too, but I'm not going to show it to you because these are the foods people should be concentrating on to get calcium from foods that aren't going to clog up their blood vessels and destroy their brain and give them cancer. Remember that many tofu products are enriched with calcium, so take a look at the labels. And beans and peas are a pretty good source, but sardines and salmon, when you're eating those foods and you're getting those small little bones, your body breaks it down. The acidity in your gut will break those bones down and release the calcium so you can absorb it. And then you get into lentils and other foods and green vegetables and green beans, but you'll notice that it's very hard, unless you're really focusing on dairy products, it's hard to get 1,000 or 1,200 or 1,500 milligrams of calcium a day. So most people don't get it. And that's why osteoporosis is so common, because we have this North American diet and you need this amount of calcium to keep your bone density, more optimal, and people fall short. Most people are missing at least 500 milligrams of calcium a day. And some people, it's more than 500 milligrams. Now, the thing is, calcium is not the whole story. Of course, for optimizing bone density, you also need the right blood level of vitamin D. Magnesium's helpful, so is zinc, so is copper, so are B vitamins to keep homocysteine down. I'll show you the whole clinical picture in a moment. But generally speaking, starting, as I have done for years, with a high-potency multivitamin, like the Adëeva all-in-one multivitamin, it's already giving you in a daily dose 500 milligrams of calcium, which is the amount most people are missing. And that first 1,000 IUs of vitamin D, that's very helpful. 200 milligrams of magnesium, the 15 milligrams of zinc, you'll see why that's important. The 2 milligrams of copper, the B50 complex to keep homocysteine down. High homocysteine can actually damage bone and cause increased osteoporosis risk. So of course, the whole formula, we'll look at it again, has all these great antioxidants in it, a B50 complex, the 500 milligrams of calcium, 200 milligrams of magnesium, extra selenium for immune support and other features, all the way down to lutein and lycopene. So this is the one that I still recommend. It's the one I've used and designed back in the 1990s, and I've made some modifications to it over time, but I still think it is the go-to sort of multi to start with. There have been many studies over the years showing that calcium supplementation can help to increase bone density, slow down the rate of loss, and even in high-risk people. But in 2007, this one groundbreaking study I thought really was the highlight, where they took individuals over the age of 50
who had already sustained a low energy fracture of the hip or upper extremity. So they already had a fracture. And they were randomly assigned to 1,500 milligrams of elemental calcium from calcium carbonate, or 1,400 IUs of vitamin D versus a placebo. But even the placebo group still got 200 IUs of vitamin D. And the bone density of their hips and fractures were taken at baseline. Then 12 months later, they looked at it again. So these are really super high-risk people. They also looked at other markers of bone turnover, like parathyroid hormone levels. If parathyroid levels are elevated, it means that it's pulling calcium out of bone because the body doesn't have enough calcium. And they also looked at functional studies. How fast could the person get out of a chair and walk a certain distance for physical performance? So after 12 months, here's what the study showed, that the people taking the high dose calcium and vitamin D reduced their bone turnover and significantly increased their bone mineral density. Remember, they were not taking Fosamax or any drugs. These are high-risk people over the age of 50. They had already had their first fracture, and they gave them calcium and vitamin D, not even at super, physiological doses, just things that would be, rational. And they're increasing their bone density over a 12-month period, even in the people who don't exercise. Now, if they did choose to be physically active, they got an even better outcome. In contrast, the group that didn't get the supplements but got the placebo, they lost bone density, and even if they were exercising, they continued to lose bone density. So supplementation becomes a critical thing that has been established over many studies to show its value, and you'll see some of the review papers in a moment that sort of summarize all of this. Another striking feature was this: people, how much vitamin D do I need to raise somebody's blood level into the ideal range? Well, in this study, just taking 1,400 IUs of vitamin D over the course of a year, right, raised their average blood level of vitamin D from 33, which is very suboptimal, to 85, which is exactly where you want it. You want it between 80 and 140 nanomoles per liter. And in 1 year, just on 1,400 IUs of vitamin D, that was enough to get it there. So that was very encouraging to see. Prior to this study, there was this great study by Lapp in the American Journal of Clinical Nutrition. There was an osteoporosis study giving women 1,000 IUs of vitamin D. And not only did it help to reduce osteoporosis, but they also showed a 50% decrease in cancer incidence because of all the great vitamin D effects on cancer prevention and also immune modulation. So you're getting this double benefit when you get people's blood level to between 80 and 140 nanomoles per liter. So the lifestyle basics are the safest and reliable way to prevent bone fractures is to use weight-bearing exercise or resistance training. Make sure that people are getting their 1,000 to 1,500 milligrams a day, depending upon what age group and risk category they're in. And usually 1,000 to 2,000 IUs of vitamin D is going to be enough for most people to get their blood level into that more optimal range. Sometimes it's not enough, but in most cases, 1,000 to 2,000 IUs is going to do it. And then there's other bone support nutrients. But regarding vitamin D, I just want to point out a couple of things. There are some people who, if they have the autoimmune disease sarcoidosis, or they have hyperparathyroidism, they have active tuberculosis, they have active lymphomas, right? You've had patients like this. Understand that in the granuloma tissue of the person with sarcoidosis or tuberculosis or lymphoma, the macrophages in there are actually making vitamin D and secreting it into the bloodstream at high amounts. Some of these people already have very, very high vitamin D levels. So before you give these people vitamin D, you want to make sure that their vitamin D is not already, quite high, because you don't want to put them into vitamin D toxicity, which would be a blood level above 250 nanomoles per liter. Remember that in the vitamin D story. How are we doing for time? So when sunlight hits your skin, you convert 7-dehydrocholesterol into cholecalciferol, vitamin D. That vitamin D is not very powerful. That vitamin D has to go to the liver, and the liver converts it into 25-hydroxy vitamin D and puts it into the circulation. That when they measure your vitamin D blood level, they're measuring the vitamin D that your liver is putting out. Then some of that vitamin D goes to the kidney, and when you're young, you can convert some of that 25-hydroxy vitamin D into 1,25-dihydroxy vitamin D, or calcitriol, which is an even more powerful form of vitamin D. And the vitamin D that you get from supplements is the same type of vitamin D that you make in your skin. It's cholecalciferol. It has to go to the liver to become a more potent form. And then if it gets to the kidney, it can become even more potent and put into the bloodstream. But as people get older, that the hydroxylase enzyme in the kidney is not nearly as effective. And so people tend to have less of this type of vitamin D circulating. But by having adequate amounts of 25 hydroxycholecalciferol coming out of the liver, that is the type of blood assessment that is used, because it's the one that can help to determine osteoporosis risk. I included these two slides because I'm going to give you this set of notes, but it shows how vitamin D stimulates certain genes in the intestinal epithelial cells that enhance the calcium absorption into the bloodstream. So it's your blood level of vitamin D that actually determines how well the intestinal epithelial cells are going to be influenced to open up the gates for the calcium to be absorbed. The full explanation is on this page. I'll provide these slides to you so you can read the details here if you're interested. But what vitamin D is doing largely is it's stimulating genes in the intestinal epithelial cells that set them up so calcium can be absorbed in an effective way. In the United States, when you look at the cohort of people 65 years and older, the National Health and Nutrition Examination surveys show that 30%, 32% of whites, 64% of blacks, 53% of Hispanics have blood levels of vitamin D below 54 nanomoles per liter, which that's unacceptable, right? So in a recent consensus conference, it was suggested that adequate vitamin D levels to prevent bone density loss is 80 nanomoles per liter. So in Canada, a lot of doctors are still going by 50 nanomoles per liter as being, as long as you're at that level, you're okay. But really, it needs to be at 80 in terms of that much blood level of vitamin D, 25 hydroxycholecalciferol. Most people can get there with at least 1,000 IUs of vitamin D. Is there vitamin D in food? There is. If you eat sardines and mackerel every day, you got a big head start, but most people don't do that. And even though some dairy products are fortified with vitamin D, is not much vitamin D. It's 100 IUs per 8 ounces. That's not very much. That's not going to be a game changer. And note that, the reason that fish have a fair bit of vitamin D in some cases is because they feed on plankton. So the plankton that's near the surface of the water can absorb ultraviolet light, and the plankton can make vitamin D. Then the fish eat the vitamin D. Then you eat the fish and you get the vitamin D that the fish got from eating the plankton. So that's sort of how the food chain works with vitamin D. So in this 2008 report of calcium and vitamin D in the management of osteoporosis, I said all the vitamin D trials from 1966 to 1999 for postmenopausal osteoporosis were evaluated in a meta-analysis to review the effects of vitamin D on bone density and fractures. 25 trials that randomized women to vitamin D supplementation with or without calcium and measured bone density or fracture for at least 1 year were chosen. The results revealed a 37% reduction in vertebral fractures when people were using supplements. Another meta-analysis looking at vitamin D said oral vitamin D supplementation means 700 and 800 IUs per day appeared to reduce risk of hip and non-vertebral fractures in ambulatory, institutionalized elderly persons, really high-risk people. Even just giving them 700 to 800 IUs a day was helpful. Giving them 400 IUs a day, which you get in a lot of just standard multiple vitamins, didn't do anything. It's not surprising. You need to get to at least 700 or 800 IUs a day. I think 1,000 IUs should be the minimum personally. And the enhanced meta-analysis showed that you really have to combine vitamin D with calcium to get the overall beneficial effect. So the vitamin D strategy is simply that most people require at least 1,000 IUs of vitamin D if they live in this part of the world. They live in Canada. There's not enough sunlight between October and May to make the vitamin D that you need. So year-round people should be thinking about at least 1,000 IUs a day. But knowing the person's blood level of vitamin D is absolutely critical. But also make sure they're getting the calcium they need with it. What about vitamin K2 and bone density? So a lot of you probably have read research on vitamin K2. So, vitamin K is required for clotting factors to be synthesized in the blood. But vitamin K2, a form of vitamin K, is also important for osteocalcin, which is a very important type of protein in bone. And so vitamin K2, as you'll see on these slides, seems to support bone density. There's no question about that. And you can get it from having green leafy vegetables and fruits and certain vegetable oils. But fermented foods are a great source, particularly of vitamin K2. So when you're getting foods that have natural probiotics in them, this is where you're getting a great source of vitamin K2. You see the rest of the slides here sort of supporting the value of getting vitamin K. So there have been different studies done to show that people with low vitamin K levels tend to have a greater risk of osteoporosis, and that there's been some studies using vitamin K2 to support bone mineral density. But it's really early stage stuff, to be quite honest with you. So there are studies using vitamin K2, I'm going to show you in a second, but really the point I want to get to is that before you tell people to take vitamin K2 supplements, which it hasn't been around long enough, my concern is that giving people vitamin K might, in some people, increase clotting factors to the point where you might increase their clot. If they're on warfarin or Coumadin, you're countering the effects of those drugs, possibly. So until we know more about it, I'm not comfortable putting vitamin K2 into a supplement. I think people should be getting it from food. There are some studies where, especially in Japan, where they've used vitamin K2 at 45 milligrams a day, showed increased bone density results in individuals that are sort of in a high risk category. So this is research you should be following over time, but there just aren't enough of these studies yet for me to be saying vitamin K2, make sure you include that as a supplement. If you want to do that, you can, but I haven't put it into our bone density, our bone support formula at this point, because I'm not comfortable enough giving people vitamin K because of the potential adverse effects that it might have on clotting. So that's just my own take on it. In terms of magnesium, there's only been one good study on magnesium showing that magnesium supplementation is helpful. What it really comes down to is magnesium is important for bone density, but if you just give magnesium alone without calcium, it's unlikely to be highly effective. So most people need 420 milligrams a day or 320 milligrams a day, depending on if they're a man or a woman, but often you can get that from just eating a wide variety of healthy foods, which most people don't do. So a lot of people fall short of the recommendation of getting magnesium. And then you wash magnesium out, with alcohol consumption, if your person's on diuretics, if they're on certain types of drugs, even stress can deplete magnesium. So often it's helpful to take some additional magnesium. In the Adëeva all-in-one multiple vitamin, you're getting 200 milligrams of magnesium a day. If the person needs more, then they can turn to other sources, which I will show you. But remember, magnesium is washed out by alcohol and caffeine and stress. So the target for most people is 200 to 500 milligrams a day. Remember that extra magnesium can also be helpful for people that have irritable bowel syndrome. On the other hand, people with chronic kidney disease, you can cause magnesium toxicity very easily if you give them too much magnesium, because it's the only way to excrete excess magnesium. And so that you can end up with what's called hypermagnesemia, too much magnesium in the blood, which can actually be a lethal problem. So in people with chronic kidney disease, you can't just randomly be giving them a lot of magnesium. But there are studies showing there's benefit to having optimal magnesium in terms of intake to support bone density. But giving magnesium without calcium and vitamin D for bone support is unlikely to be highly beneficial. You want these things all working together. And the same is true for copper and zinc. So copper is required to cross-link collagen. When you cross-link collagen, it increases the microarchitecture of the protein, and your bone support is better. So you need a little bit of copper to do that. But zinc is also important because with enough zinc, you secrete insulin-like growth factor 1, which has anabolic effects on bone densities. Studies show that when people's IGF-1 levels fall, that they're more prone to osteoporosis, and that when you give people zinc supplementation at just 15 milligrams a day, it increases their IGF-1 level and their bone density is better. So because the average intake of zinc across the population is only 8 to 11 milligrams a day, most people have a marginal zinc deficiency. And that marginal zinc deficiency shows up in a number of ways. People often will have decreased immunity. They have poor wound healing. They can't taste their food as well. When the lights go off, dark adaptation is not as good. And they start losing their lean mass and their bone mass at a faster rate because their insulin-like growth factor 1 levels are lower. Supplementing with older people with zinc has increased their IGF-1 level. So that's an important consideration. So in a high potency multivitamin, that 15 milligrams of zinc is very important. But if you give zinc without copper, then you end up having a copper deficiency because they get absorbed using the same carrier. So normally you would have a ratio of zinc to copper in a supplement that's 10 to 15 to 1. as we have in the Adëeva multivitamin to ensure that both zinc and copper can get absorbed adequately enough to perform these roles. If you impair the absorption of copper, you end up with anemia because you need copper to make red blood cells. So these are the references on zinc and copper. Another thing to point out, as I mentioned earlier, is that if your homocysteine levels start to rise above 8 or 9 micromoles per liter, high homocysteine interferes with the cross-linking of collagen and bone, and you have a defective bone matrix, which is linked to increased osteoporosis risk. Remember that the way that you recycle homocysteine back to methionine by giving it the methyl group that it needs is with folic acid, vitamin B6, and B12. So that B50 complex that's in the high potency multivitamin that we have is highly beneficial also at helping to maintain more optimal homocysteine levels. Then from the epimedium herb, there's the Icarian flavonoid. This is an incredible flavonoid because that flavonoid has shown in postmenopausal women, if you give them 60 milligrams of the Icarian flavonoid, it has increased their bone density in the neck of the femur and lumbar spine just in a 24-month study in 85 postmenopausal women. So the reason they did this study is because experimental studies had shown that the Icarian flavonoid stimulates osteoblastic activity in bone, and it inhibits osteoclastic activity. So it's doing exactly what you want, stimulating new bone growth and inhibiting the breakdown of bone, creating a net effect of increased bone density. So the Icarian flavonoid is an incredible discovery that doesn't get the attention that it deserves. And the same is true of soy isoflavones. Soy products, and soy isoflavones in particular, have been shown to reverse lumbar spine bone loss in postmenopausal women for a number of reasons. That it enhances the absorption of calcium from the gut, and it also helps to act as sort of a phytoestrogen to keep calcium in bone. So there's this great review paper in 2016 showing all the positive effects of soy isoflavones on decreasing bone loss and stimulating bone formation. The dosage that you need would be 70 to 126 milligrams of soy isoflavones. That seems to be, in human studies, the amount that's required to really slow bone loss and stimulate bone formation. So using soy products and or a soy protein shake, if it has isoflavones in it, a lot of soy protein shakes don't have isoflavones in them, but certainly soy foods are going to have that. And remember that I said earlier that a high protein intake can cause calcium to be leached out of bone. But as people get older, they tend to not eat enough protein. So more elderly people often are protein deficient, whereby giving them more protein actually has the opposite effect, helping to support their bone density. So there are these studies showing that make sure the person's at least getting the RDA for protein, which would be about 1 gram of protein per kilogram of body weight. Doing that has been shown to actually help support the bone density. If you're not going to get it from food, at least give them a protein shake that will have a little more protein in it. My preference is to give people whey protein because whey protein has the best amino acid profile to support all kinds of lean mass throughout the body and support immune system function as well. The protein also increases insulin-like growth factor, which also has osteotrophic effects. So I like the idea of, in older people, looking at their protein intake as well. If it's suboptimal, you're going to need to give them protein. So these are the references on protein. Remember that too much vitamin A can actually stimulate osteoclastic activity and cause bones to break down, leading to increased risk of bone fractures. So if a person says, I'm already taking a multiple vitamin, say, bring me the multiple vitamin. If the multiple vitamin has more than 2,500 or 3,000 IUs of preformed vitamin A, that's likely going to increase the risk of osteoporosis over time. Whereas with beta carotene, your body only converts beta carotene into vitamin A if the body needs vitamin A. If it doesn't, the beta carotene just stays and serves its role as beta carotene in the body. So high amounts of beta carotene don't increase the risk of fractures. Silica also helps to increase the cross-linking of collagen, and the mineral boron has been shown to slightly increase estrogen levels, which could help support bone density. Of course, exercise, whether it's weight bearing or resistance training, helps support bone density and slow bone loss. And if you're getting calcium and vitamin D and other nutrients, it can help to increase bone density. So how much exercise does a person need to affect their bones in a positive way? It depends on their current minimal exertional strain. In other words, whatever the person's doing now is sort of what their bones are used to. So if their bone density is at a certain level and they're doing certain things now, let's say they have a desk job and they're very sedentary. Just walking, you're doing a walking program actually increases the minimal exertional strain that the bones are used to, and you'll start getting a positive effect on bone. If they're already on a walking program and their bone density is not good enough, then you're going to need resistance training of some kind. Remember that aqua aerobics, even though it's good for arthritics who feel much better in the water, it's easier on their joints, it's not really weight bearing, so it doesn't do a great job of supporting bone density. So you want to give them other things to do outside of the water that create some resistance so they don't lose their bone density. Remember that if they already have osteoporosis, you don't want things where there's a lot of forward flexion, like, you know, stationary cycling, where you're really bent forward. If you're on a recumbent bike and you're sitting back, that's one thing. But someone's on, I don't want to single out Peloton or any other make, but if you're leaning forward on a bike, putting that pressure on the thoracic spine can cause vertebral fractures of the thoracic spine. So you want to avoid things that are going to cause spinal compression, including traditional sit-ups and abdominal crunches. That's not appropriate for someone that has osteoporosis, whereas spinal extension exercises are very ideal. There's a great summary of all of this in the 2005 Osteoporosis update in the American Journal of Clinical Nutrition. This was really the last update that was published on this, believe it or not. But what they say is that the use of calcium and vitamin D supplements in an elderly population has been shown to be cost-effective for hip fracture prevention. Medical professionals need to be aware of the importance of ensuring adequate calcium and vitamin D intakes for patients on osteoporosis therapy. Even if they're on Fosamax or Actonel, they still need to be paying attention to these nutrition and lifestyle factors. The effects of calcium and vitamin D should not be seen in isolation from other dietary components. In other words, that's not the whole story. How much fiber they're getting, they're exercising. How about caffeine and alcohol? What about all these other things that can have an influence? It helps to determine, what your recommendations are going to be. Are they getting fruits and vegetables to get the buffering agents? All these other micronutrients need to be factored into the game. And that's why I like a high potency multivitamin as sort of a baseline, to be honest with you. So the supplements of importance, in my view, I usually recommend the Adëeva all-in-one multiple vitamin mineral. And then in certain cases, if their needs are greater, I'll include the Adëeva bone support formula, which I'll show you. You might want to consider giving people separate vitamin K2 and or a soy or whey protein shake or a supplement containing soy isoflavones. So the Adëeva all-in-one multivitamin, again, the nutrients that support bone all in one bottle. Here you have the 500 milligrams of elemental calcium, 1,000 IUs of vitamin D, 200 milligrams of magnesium, 15 milligrams of zinc, 2 milligrams of copper, the B50 complex to keep homocysteine down, along with everything else that's important, right? Not vitamin A that's not going to cause bone loss, 15,000 IUs of beta carotene, that extra vitamin C for immune health and as an antioxidant, 400 IUs of vitamin E for immune support. There's the B50 complex. There's the calcium, a little bit of iron, not going to be toxic unless you have hemochromatosis. Of course, you couldn't take anything with iron if that's the case. There's the first 200 milligrams of magnesium. People are missing the 15 milligrams of zinc, the selenium at 200 micrograms, and then all their nutrients of importance. Here's the copper at 2 milligrams, all the way down to lutein for the back of your eyes to help reduce risk of macular degeneration, the leading cause of blindness in people over the age of 55, and lycopene for the prostate gland and the cervix of the uterus. Now, if the person is in a higher risk category or their diet is not great, then you might want to also include the Adëeva bone support formula, where in 2 caplets you're getting another 800 milligrams of vitamin D. You're getting another 600 milligrams of calcium. You're getting another 300 milligrams of magnesium. You're getting the icariin flavonoid. Like someone with osteopenia or osteoporosis, I'm introducing this as well. You're getting some hydrochloric acid to increase stomach acidity to absorb these things more effectively, the silica from bamboo extract, and a little bit of boron. So I put all those together for someone that needs extra bone density support. So if the person took the multivitamin from Adëeva and the bone support, and they took the full adult dose of both each day, they're getting in total the first 1,100 milligrams of calcium. They're getting 800 IUs of vitamin D, 500 milligrams of magnesium, the 60 milligrams of the icariin flavonoid, 3 milligrams of silica, 1.5 milligrams of boron, the B50 complex, 1,000 milligrams of vitamin C for collagen, right? And 2 milligrams of copper. If you add to that weight-bearing exercise and a healthy diet, you have the formula, the lifestyle formula. So on each of your patients or clients, and this is my last slide, to determine what it is you want to do with them, first you say, is this person a candidate for bone density testing in the first place? Do they meet the inclusion criteria that I showed you earlier? If they do, and you're not able to order a bone mineral density test yourself or do one in the office, then you write a note to their physician saying, you know, this person meets the inclusion criteria. They haven't had a bone mineral density test. That might be something to consider. Often the family doctor is thankful. I mean, they're so busy with all the urgent things they're dealing with. Sometimes this can slip through the cracks. Have they already had a bone density test? That's a question you want to ask. And they say, I've had one. Okay, what were the results? They told me I'm normal. Well, that's great. I have osteopenia. Oh, that's interesting. Oh, yeah, I have osteoporosis. Oh, that's and what treatment is being applied? What's their serum vitamin D level? Everyone should really know their blood level of vitamin D. They should request it. I think it costs like $25 in Ontario to get your vitamin D level. But it's helpful to know that if it's below 80, you know, you've got to take action. And then you have to try to get a snapshot of their diet to see what is their average calcium intake from food and supplements right now. That'll help me decide what I want to recommend going forward. And then what about their exercise routine, or do they have a physically demanding job? I don't have an exercise routine, but I work construction on a job site. I carry bricks up a ladder all day. Oh, your bone density is probably pretty good. But if they have a sedentary job, you might have to actually prescribe a specific exercise program for them. Look at how much vitamin A they're getting from a supplement they might already be on to make sure that it's not too much that's going to be causing bone catabolism. And what are the other factors that are related to their life? You know, are they a smoker? What's their alcohol consumption like? How much caffeine? Do they eat a lot of foods that have sodium? Do they eat a jar of pickles every day and have, you know, processed soups that have lots of sodium in them? So you want to try to look at the whole snapshot of their world. And what's their family history? And what's their body frame? Are they really frail and weak and very little muscular development? And to try to devise a program that's going to help them, or make sure they get a bone mineral density test if they haven't had one. So that's sort of the current state of knowledge related to the world of nutritional medicine on preventing bone density issues in the complementary management of osteopenia and osteoporosis. So I hope that was helpful. If you have any questions on this, you can always email me at drjames@adëeva.com. And remember that we will be sending these slides to you along with the recording of today's webinar. So I want to thank you for attending.